Hello, and welcome back to the Age of You podcast, a sweet secret to longevity. My name is Rina, and I'm your host. Today's topic is likely something you don't hear about very often, although it impacts half of the world's population. It is the place of women in research and medicine. Women are understudied, undertreated, and are more likely to be misdiagnosed or undiagnosed compared to men. As you can imagine, this is a very complex and multi-layered topic, and so requires us to consider it from quite a few different perspectives, which is exactly what we plan to do in our conversation. We will start off by talking about reasons why there is less women participants in medical research, all the way to negative consequences of male-centric medicine. And for this conversation, I am joined by two amazing women who are more than fit for the task. We have Dr. Alka Patel, who is a GP, lifestyle medicine doctor, author, and podcaster who guides her patients towards a lifestyle which helps them achieve longevity and reduce stress. And of course, we have Dr. Julia Jurić, who is a molecular biologist working as a scientific researcher in the field of glycobiology. She specializes in sex hormones and antibodies from the perspective of women's immunity. Her mission is to promote healthy aging and wellness. Hello and welcome. Hello, Rina.
Hi, Rina. Lovely to be here.
So to start us off, as I said, women have in the past and still are today been underrepresented in medical research. And at this point, I'm guessing many of our listeners are wondering why that is. So looking back, I will give an example which led to more regulations regarding inclusion of women in medical research, and that was the aftermath of the thalidomide drug in the 1950s. So thalidomide was used for quite a few different purposes, but it was also marketed as a nausea reliever and a sleeping aid for pregnant women. And depending on where you lived, it was either available through prescription or over the counter. Sadly, it resulted in severe congenital malformations, which affected over 10,000 babies born worldwide. And so this tragedy introduced an additional concern when it comes to working with women of childbearing age in research, because, as you can see from this example, it could inadvertently impact the next generation. Now, as these regulations were put into place, one thing became more and more obvious, and that was the fact that the more precautions you took to protect women, the more expensive these research trials became. One is the cost of pregnancy tests, which usually have to be carried out throughout the trial if there is a risk to the mother or the baby, or if the pregnancy would impact the results of the study, which very often it would. And the second are tests which might have to be carried out to determine where the woman is in her menstrual cycle, because the fluctuations of hormones which happen throughout the cycle over the month can change the results of the study depending on what is being studied. And so, as you can see, both to protect premenopausal women and to cut the costs of research became largely male-centric. And over time, it contributed to this assumption that for the most part, what is true for men should be true for women as well. So Dr. Patel, could you start us off by highlighting why this research model, why this type of research has put women at a disadvantage with regards to their medical care?
Oh, it's great to kick off this topic with this question. Thank you, Rina. So, there's probably two examples that come to mind here. One is drugs, and the other is disease. So, if we think about drugs or medication, I came across a while ago a letter that was written by the US General Accounting Office, and this was written to the US Senate. It was back in 2001. And what this particular letter highlighted was the withdrawal of 10 prescription drugs. So, these 10 drugs were withdrawn by the FDA, the Food and Drug Administration in the US, and this was between 1997 and 2001. And what was found was that 8 of these 10 prescription drugs, they posed a much higher health risk for women compared to men. So 4 of these might have led to more adverse events in women because they were simply prescribed more to women. And the other 4 might have led to more adverse events in women, even though they were prescribed to both men and women. And when I read this, there was just really one question that this very single observation raised for me, and that was simply, why did research not pick up on this before the drug hit the markets, before it went out to the population? Now, look, there might be several reasons for this, but one of those has to include research not being done appropriately in women, which means that by default they're then put at a much higher risk of drugs that they are consuming. So this is really, really important to think about. And another example, if we look at disease, something that's becoming increasingly common is autoimmune disease. And autoimmune disease, according to the National Institute of Health, affects more than 20 million people in the US. It's a huge cause of disability. The prevalence really is increasing. And again, interestingly, women represent more than 80% of autoimmune patients. So when I'm talking about autoimmunity, this is conditions that affect the skin, that affect multi-organs, kidneys, liver, etc. So there's very significant physiological impact, and of course that physical and mental well-being as well is impacted. Now, autoimmunity is certainly an area which needs a lot of research, and if we look at things like psoriasis or alopecia areata, two conditions that are felt to be autoimmune triggered, actually they affect women differently to men. Um, so you might think the prevalence of something like psoriasis or psoriatic arthritis is very similar between the sexes, but the experience of something like psoriatic arthritis is very different in women compared to men. Women get more peripheral arthritis, so lots and lots of joints are affected. They've got much poorer responses to treatment. They're less likely to go into remission. And another interesting thing that you'll find with autoimmunity is that women do report changes during menstruation, during pregnancy, during the menopause, and all of this is driven by female hormones. So it's really clear, isn't it, that we just need a better understanding of all those biological pathways that trigger and perpetuate illness, because that's the way to really develop targets to better treat this. And I hear what you said. I know, certainly there's risks in research in women, because there's another little body to think about in pregnancy, for example. But there is a risk, of course, of not doing this research, which far outweighs perhaps doing the research as well. So I think just even these two scenarios themselves really do raise the case for really thinking about why are women not studied in research, again through varying normal physiological processes that they're going through.
Now, when it comes to sex hormones, which you've just mentioned, most of our talk today will focus on differences between men and women, which are based on sex hormones. And I think many of us are used to thinking of them as male versus female hormones, when in reality they are present in both sexes. So, Dr. Jurić, could you briefly explain the importance of these hormones in men and women?
Yeah, thank you for asking me such an interesting question about sex hormones. So, yes, people are thinking about hormones, and especially sex hormones, as either female hormones and male hormones. But in fact, in men and women have the same hormones in their body. So, estrogens, progesterones, and testosterone are all are the same hormones in men and women, but the difference is in their concentration. So women have more of estrogens and progesterone and less of testosterone. So estrogen and progesterone are main hormones, sex hormones in women. And testosterone is the main male hormone, and it's in bigger concentration than progesterone and estrogen. But although we have those other hormones in lesser level, their hormone balance is important for health in men and women. By this, I mean that although in small concentrations, testosterone brings great value to health in women. It protects bones. It is very important for the sexual desire in women. It is also important for cognitive function in women. And if we turn that around, estrogen is very important for sperm production in men and for overall health in men.
Thank you for introducing sex hormones. I don't doubt we will keep coming back to them throughout the conversation. I want to go back to pregnancy for a moment. This reluctance to study pregnant women also limits the options that providers have when prescribing medication. We can't simply assume that all pregnant women are healthy throughout the duration of their pregnancy. Sick women get pregnant, and equally, pregnant women get sick while they're pregnant. So, Dr. Patel, have you had experience where you might have felt limited with regards to what medications you were allowed to prescribe to your pregnant patients?
Yeah, that's a really interesting question, actually. So, here in the UK, we have a formulary which is called the British National Formulary, which looks like this. I can show you one of those. So, it's one of this is a little bit of an old version, but and then certainly an online version of it as well. So, it's a publication that's produced by the British Medical Association and the Royal Pharmaceutical Society, and it's produced under this authority of a joint formulary committee. And why do we have this? Well, the idea of having this formulary is so that prescribers get up-to-date information about safety of medicines and how to prescribe them. And when you look at the BNF and what it says about drugs in pregnancy, it's very clear to only prescribe if the expected benefit to the mother is greater than the risks to the fetus. And it says avoid all drugs if possible, especially during the first trimester, so those first 12 weeks. And it says drugs which have been extensively used in pregnancy and appear to be safe should be prescribed in preference to new or untried drugs. So what this reads to for me is, well, it's basically human experimentation, isn't it? Try a drug out on a pregnant woman. If it feels okay and if it stands the passage of time, then use it, otherwise don't. So this is actually not great practice, and doctors don't want to take this risk. But we have to really think about, inclusion and fair inclusion of pregnant women in clinical trials. And I did come across a very interesting paper by a team led by Van de Graaff. And the observations in this paper were very much along the lines that since pregnant women are very underrepresented in clinical research, what we need to think about is the exclusion of pregnant women from research has to be justified unless there's actual compelling scientific reason. So when we talk about fairness and fair inclusion, what we mustn't think about is the implication that pregnant women should be included in every research project going, so that's fair and there's fair representation. What actually is likely to be more beneficial is having separate trials in pregnant women. So once we know that interventions are perhaps different in women, or even if there are no differences and we're making that assumption, then having trials in pregnant women will actually lead us to have more information. Now, we talked about this a bit earlier, didn't we, that there's some objections here to including pregnant women in research because of vulnerability and that balance between the maternal risk and the fetal risk. There's another living being here to think about. So I guess when you first hear about these objections, your sort of instinct is, yeah, this is valid. We've got to keep women and mother and baby safe. But think about not performing research. What it does is it magnifies risks. So risk can be controlled in research trials, but if you push that risk into a clinical setting, there's huge challenge. And especially for clinicians like myself, we're faced with making all these treatment decisions for pregnant patients with very limited evidence for efficacy and safety. And sometimes there's a huge reluctance to prescribe, which means that our care for women is affected as well. You mentioned thalidomide right at the beginning. And if we look at nausea and vomiting in pregnancy for women, these are not uncommon symptoms that women have at all. They're fairly commonplace. But usually the advice is it's okay, those symptoms will go. Nausea and vomiting only lasts up to 12 weeks, maybe 16 weeks if you're unlucky. So just let that time pass. And there's a reluctance often to prescribe the drugs because, of course, inherently there's risks associated that we don't know about and we don't have, and they're unlicensed or they're prescribed off license. So whilst we do prescribe, there's always that dichotomy of should I, shouldn't I? Should women just put up with their symptoms because we haven't got safe, licensed treatments? And that is inherently unfair, isn't it?
And particularly, I imagine it's difficult with women who might have multiple diagnoses, multiple, chronic illnesses that they have to manage throughout their pregnancy. They can't simply stop their treatment for 9 months and hope for the best. But I want to pick up on something you said earlier, which is the fact that women might experience the same illness differently compared to men. And one of the common examples our listeners might have heard about are heart attacks and strokes. Initial symptoms of a heart attack in a woman might be very different from those in a man. So since our medical symptomatology is largely based on this research, which is mainly based on men, our medical symptomatology is then going to be mainly male pattern symptoms. We're going to mainly base all of these diagnostic requirements on men. And so can you explain the way this impacts the efficacy with which these same conditions might be diagnosed in women and the treatment they would be offered?
Yeah, heart attacks is a really interesting area to have a look at. And of course, we know heart disease is the biggest cause of morbidity and mortality that we know of. So there's again research being done on this. So according to the British Heart Foundation, they did a funded study some while ago, and they found that more than 8,200 women in England and Wales could have survived their heart attacks had they been given the same quality of treatment as men. So looking at this research, it was done by the University of Leeds, and they looked at anonymised data from the UK's heart attack registry. And this was looking at the outcomes of over 6,900 people. Sorry, not 6,900, 690,000 people, add a few zeros onto that. And these were people who'd been hospitalised for a heart attack in England and Wales over a sort of 10-year period between 2003 and 2013. And the findings were very, very interesting. So first of all, women were found to be more than twice as likely to die in the 30 days after a heart attack compared to men. So 5.25% of women compared to 2.3% of men. And there were lots of additional findings. So another finding was women who had an NSTEMI, so it's a type of heart attack where your coronary arteries are partially blocked. They were 34% less likely than men to receive an angiography within 72 hours. Angiography is the video images that reveal all the narrowings in the arteries, and it's a really important step because it helps the doctors to decide what to do next. And of course, the earlier you receive your angiography, the better your outcomes are going to be. There's another form of heart attack, a STEMI, where the artery is completely blocked, and women who had a STEMI, they were 2.7% less likely to receive those reperfusion and emergency procedures. So 76.8% of women versus 78.9% of men. Now, listeners might be thinking, well, these are small differences, and they might seem like small differences in isolation, but even those small deficits, if you add those up through kind of pathways of care, they get intensified to a considerable survival disadvantage in women. Now, we might think, why is this? And these differences might be down to some bias, but they're also down to biology, right? There's differences in heart attack symptoms, there's differences in health-seeking behaviors, there's differences in response to treatment. So if you don't research this in women specifically, then you can't optimize the outcomes. And we're talking 3 women every hour dying from heart attacks, which is huge. And you're right, the symptoms are different in women, and there's symptoms that we don't often associate necessarily with heart attacks. I'd contributed to a piece in the Daily Express last year, which did highlight a variety of heart attack symptoms. So something like nausea and vomiting, for example, is a key symptom in some cases for a heart attack. Sweating. Now, the body sweats to keep your body temperature down. So if your heart has to work much harder to pump blood through your arteries, then your temperature is going to increase as you're spending much more energy. And of course, you then sweat. And this can be very profuse, sudden sweating. It can be sweating that occurs at night. So night sweats. Who gets night sweats? Menopausal women. So as a woman, don't assume that your night sweats the menopause. And of course, this assumption is made by clinicians as well. Of course, we think about a whole plethora of symptoms, but really important to think about that surge of nausea or unexplained vomiting or unexplained night sweats could be alarm signals as well.
Absolutely, and we have to do better than retrospective studies. We have to do more work in prevention rather than just reporting when these issues happen. I particularly want to bring out the example you mentioned, which is the fact that women were less likely to receive timely coronary angiographies. So in this example, it's not only that they are not as successfully diagnosed as men, it is the fact that they are not even offered the same diagnostic measurements as men in many cases. So I thank you for bringing this up and thank you for such a thorough answer to this question. But now I want to focus more kind of biologically, what happens in the body, what is it that makes men and women different. So many conditions, particularly those inflammatory in origin, disproportionately affect women compared to men. So Dr. Jurić, could you explain some of the reasons why that is?
Yes, one of the reasons that inflammatory, which would also include autoimmune diseases, are affecting women more is because we have this component of our sex hormones, and especially estrogen, which has been associated with immune system, and antibodies, which are the humoral component of our immune system. So what antibodies do is they defend our body by making an inflammation. And women are very successful in that. So if you take, for example, vaccination, women would elicit more antibodies, would produce a higher concentration of antibodies after immunization than men. If they catch or have some kind of a viral infection, they would elicit again and mount a more vigorous immune activation, have more antibodies, and they would fight this viral or bacterial infection better than men. But on the other hand, this could be also bad for them, because this overactivated immune system could bring them pathology. So this could, if some kind of a mistake happens in immunity, antibodies will become autoantibodies. So they will start to attack their own tissue, like in thyroid problems like Hashimoto thyroiditis, and you would have a problem with overactivated autoimmune autoantibodies, which will then produce some kind of a disease. So not being protective ones, but being the ones that do you harm. And one such also condition with autoimmune antibodies associated with inflammation is rheumatoid arthritis. So those are also autoantibodies which attack collagen in the joints. And women, this is very much associated with sex hormones. And what we found in our research is that women who have rheumatoid arthritis, when pregnant, their antibodies become more anti-inflammatory, and the symptoms of inflammation within rheumatoid arthritis are decreased. So women feel like there is no more disease going on in their bodies. So the disease is in remission. And after they have a baby, after delivery, the level of estrogen and progesterone, which was really high during the pregnancy, which was protecting them from those adverse inflammatory progress, this is now decreased, and the inflammation starts again. And what we observed is that those women constantly have autoantibodies, but the glycosylation, those glycans, those small parts on antibodies, were the key factor that changed. So they turned from the pro-inflammatory to anti-inflammatory in the pregnancy with the high level of estrogen and progesterone, going back to the pro-inflammatory after the levels of estrogen and progesterone was lower. And we also see something similar happening when women enter menopause. So during the perimenopause, during the menstrual cycles that become irregular, with age, level of estrogen and progesterone decreases. And actually, antibodies lose their anti-inflammatory ability, and the chronic low-grade inflammation in women throughout the perimenopause increases. And you have chronic inflammation, so you have inflammatory chemicals in your blood, which then harm the blood vessels. And when entering menopause, this inflammation is flared up, and you have a lot of problems with cardiovascular diseases. So the women who enter menopause are twice as likely to have cardiovascular diseases than men which have normal menstrual cycles. Also osteoporosis. Also, they feel decline in cognitive function, and they have many other symptoms which could mislead the doctors to diagnosing them with some kind of other condition than the one that is kind of the source of all their trouble and all their symptoms, and this is low level of sex hormones. And this inflammation that's promoted with the low level of sex hormones is also something that should be taken into account when considering CVDs, so cardiovascular diseases. If the women had timely interventions, so timely preventative hormonal replacement therapies or some other managing drugs that manage the level of sex hormones or that decrease chronic inflammation, they would probably not develop the cardiovascular diseases, because the level of sex hormones is declining even. So perimenopause lasts from 7 to 14 years. It's not something that happens overnight. So you can still do some protective interventions to save women from having a heart attack or some other cardiovascular condition.
We will make sure to talk more about menopause a bit later on. But before we do, I want to pick on something you mentioned, Dr. Jurić, and those are hormone treatments. Now, women are more likely to take exogenous hormones compared to men. This may be in the form of contraceptive pills, IUDs, hormonal replacement treatments for menopause. So, Dr. Patel, why would you say it is important for your patients to mention that they are taking these hormones in addition to their other treatments?
Yeah, I mean, there's obviously a very clear indication and interaction, really. So ultimately, some medications don't let hormones do their job. That's what it comes down to. And some medications, if you take them at the same time as, say, your contraception, your birth control, then you might not have the same level of protection that you think that you do. So some antibiotics like rifampicin or antifungals like ketoconazole or anti-seizure medication like carbamazepine, they do impact on how estrogen is metabolized and broken down. Even some of the herbal stuff, the St. John's wort, for example, or garlic pills for blood pressure, or flaxseed that we use. There are so many interactions. And again, back to the BNF, if you look at HRT, there's at least 31 drugs that I found listed in the BNF as interacting with HRT. Again, back to our earlier conversation, interestingly, if you look at these interactions with something like HRT, of these 31 drugs, 19 are based on anecdotes, 9 are theoretical, and there's only 3 studies that confirm this correlation and interaction with HRT. So my question then is, well, why is so much anecdotal again? Why are we putting ourselves at risk? Where are all these studies that we should be utilizing?
I think one of the drawbacks of male-centric pharmaceutical research is that medications which are tested and approved on men are not guaranteed to have the same effect on women. And this is because for many drugs, women metabolize them differently compared to men. And even when it comes to just women, the way they process some drugs might differ depending on what stage they are in their menstrual cycle, which introduces a completely different question, and that is, should men and women be taking the same drugs in the same doses? Should they expect the same side effects if they metabolize these medications differently? So, Dr. Jurić, do you think there would be a benefit in having sex-specific side effects listed on drugs and sex-specific doses for medications, which would be different for men and women?
Yes, that would be very beneficial for women. And today, everything is about personalized approach to treating every person. But if you're personalized in treating men, you should be also personalizing treatment for women. And I think that with hormones, women are much complex than men. And as my experience is that every study, even a clinical trial, has to be well controlled. So in men, you can do this. So they don't have fluctuations of hormones during the menstrual cycle. So for women, it's like you cannot catch them for their tail. So they're always changing in hormones. So you don't have a really well defined what kind of hormone level you have, because they're always switching throughout the cycles, throughout the periods of their menstrual cycle. And this is maybe the basic reason why this is very hard to explain, because if you would find some kind of adverse effects, or you wanted to find a real dosage for a woman, and you know it for men, and you would like to find the real dosage of the drug for women, then you would find some kind of a result, and you still don't know whether hormones in that period of the menstrual cycle might have affected the dosage for the women. And you cannot really say, okay, now in the first part of the menstrual cycle, if you are in the first part of the menstrual cycle, take I don't know, slightly less or slightly more, because everything is done in pills. So one pill for all. This is what the pharmacy companies are the happiest with. But for women, it's different. So men and women have different metabolism. They have it because of many reasons. One of them are sex hormones. So if you take the drug, so the drug absorption is different, the drug distribution in the body is different, and again, the drug excretion is different for men and women. Enzymes that metabolize the drug are sometimes more active in women and sometimes are more active in men. Sometimes the drug stays longer in woman's body than in men. So women would need lower dosage if the drug stays longer. If they have less active enzyme that metabolize the drug, again, the dosage should be half from the men, or whatever that the clinical trial says. And those enzymes are situated in the liver, so we have different liver metabolism. And I think that what should be avoided with the drugs is overdosing, or the case when you have too low doses of the drug for men and women. And this is what we should be really thinking about, because if you're treating men and women for chronic diseases, so chronic drug administration for managing chronic diseases is something that you are doing your whole life. So it takes decades. If you have high blood pressure and you're taking the same amount of drug as men are taking, and you know that women should be taking half of the dose, you're overdosing women. And maybe you're, for long run, you're doing more harm than good to women. So I think that clinical trials should, in any case, include women and their hormonal state into consideration when when we are thinking about drug dosage.
We've talked about chronic illness, we've talked about how the same medications might impact men and women differently. What I want to talk about now, briefly, is pain. Women have much higher rates of chronic pain disorders, which are linked to neurological function, compared to men. And this might include anything from fibromyalgia, chronic fatigue syndrome. What's also very interesting is that the experience, the severity of pain, very often changes during the menstrual cycle. So for women who have migraines, it might be that their migraines get worse during particular parts of their menstrual cycle. So Dr. Jurić, could you explain how fluctuations in hormones which happen over the month, over the cycle, impact the susceptibility and experience of pain?
Yeah, women are very emotional, and they're full of emotion and empathy. And during the menstrual cycle, the fluctuation of sex hormones is very dynamic. In the first part of the menstrual cycle, in the follicular phase, you have increasing level of estradiol. Then you have ovulation, and the level of estrogen is lowering a bit, but then you have a production of progesterone. By the end of the menstrual cycle, those two hormones decrease. They need to decrease because we are expecting menstrual bleeding and the beginning of another menstrual cycle. But sex hormones are really important for managing inflammation. They act anti-inflammatory, and when their levels are really low, then you have inflammatory chemicals, or you have inflammation, which is increase in inflammation. By the end of the menstrual cycle, there are certain chemicals produced and released into the bloodstream, which are called prostaglandins. Prostaglandins go through the whole circulation and also come into the brain. And when the level of sex hormones goes very low, and you have low sex hormones during the menstrual cycle, which happens in that period of perimenopause, when you have irregular menstrual cycles, when you are missing ovulation, then you don't have enough of the progesterone produced to counteract with the estrogen. You get a lot of prostaglandins in the circulation. And this is inflammation, which with the circulation goes also into the brain. And it's the blame, it is the one to be blamed for neuroinflammation. So the neurons in your brain are more sensitive to any excitement they encounter. So they are more sensitive to the level of that chemicals, prostaglandins, and then you feel pain. So they are manifested as migraines. You also might feel more pain in your neck, in your shoulders. So you have more sense of the pain in your whole body because of increase of that inflammation, which happens with the lowering of sex hormones by the end of the menstrual cycle.
I find it very fascinating how the same condition, the same problem might be experienced more painful, less painful, depending on where you are in the month cycle. And it's something I don't really hear about very often. But Dr. Patel, do you see potential for treating chronic pain conditions based on where the patient is in their menstrual cycle?
That's a very interesting question. I mean, certainly, as Dr. Jurić has said, we know women rate pain higher in the menstrual or premenstrual phases rather than in the mid-menstrual or ovulatory phases. So there clearly is this distinction. I think the important thing is to have a conversation, with patients, with clients about these fluctuations, to get them to recognize and understand the fluctuations that they can experience. And I think another area which we haven't really touched on is the conversation with employers. So making employers aware that pain can vary at different times. And it's not so much, you've got pain on Monday again. Why are you always off on a Monday? Well, actually, it's the female cycle. So there's always lots of judgment and bias in that. So I think these are the conversations that we should be having much more widely.
Just to add, one thing that you can do, you can have more rest when you know that these days in the month will come. More rest, less stress. And you can also, what is very interesting, you can supplement magnesium. Apparently, when the levels of estradiol are low, then your neurons are lacking magnesium. And magnesium is very important in cells sensing, so in receptors on the cells or neurons sensing the pain. So you could be actually helping yourself with increasing the magnesium, which would then not then would kind of make cells more robust to feeling excitement and reflecting this excitement as pain.
I bet it's a pain management technique our listeners haven't heard about yet. While women in general are underrepresented in medical research and more frequently misdiagnosed compared to men, I think we have to make sure to mention that women of color are particularly underrepresented. So, from your experience, Dr. Patel, can you comment on this issue?
So again, there have been studies on this as well, haven't there? There was a 2019 study that I came across in the American Journal of Emergency Medicine, and they looked at over 14 previously published studies on what we've just been talking about on pain management, and found that Black patients were 40% less likely to receive medication for acute pain compared to white patients. So we're talking about something that is significantly significant here. So this is not an issue that is not known about. Again, the question is, what do we do about this? There's other areas as well beyond pain, certainly from sort of medical training. When we look at dermatology or skin issues, for example, they present very differently in different ethnicities and different skin tones. And so that diagnosis then is affected, though your delay to receiving appropriate treatment is reflected as well. And again, going back to what is this about? Is this about inclusion in research? Is this about the medical curriculum being too narrow? So I think we have to again get back to the root, which is what we're very keen always to do, is to get to the root of what's underlying this.
I'm glad we brought this up. This topic, I think, deserves its own episode. But moving on, when it comes to men and women differences, again, one of the ways in which men and women differ is also with respect to aging, particularly in the period of menopause. Now, Dr. Jurić, you've already talked about menopause, but Dr. Patel, if you could just reiterate, what specific hormonal changes happen during this period?
Yes, sure. Of course, Dr. Jurić obviously has been through this, so it's very important to reiterate it because it's so core, isn't it? So if we just stick to the three primary sex hormones that we know, estrogen, progesterone, and testosterone. So again, as Dr. Jurić said, it's estrogen that's stimulating our breast tissue, it's maintaining the blood flow in the vagina, supporting lubrication, it's what causes the lining of the uterus to thicken up during the menstrual cycle as well. It preserves bone. We've been talking about that as well. So during the perimenopause, and Dr. Jurić, as you said, this can be a long piece of string, can't it? 7 to 10 years, you said. So during that period, these levels are fluctuating and they become unpredictable. There's no smooth, gradual decline. It's more like a really bendy roller coaster that women are going through. And eventually, the production of estrogen then falls to a very, very low level, which then results in those symptoms that we hear often about, such as bloating or breast tenderness or heavy vaginal bleeding, which you get with higher levels, and lower levels you get flushes and sweats and palpitations, bone loss, vaginal dryness. So that's what's happening with estrogen through the menopause and the perimenopause. Progesterone is different. Progesterone is essentially preparing the lining of the uterus for a fertilized egg. So its production stops in a cycle when there's no ovulation. And of course, after your very final menstrual period of the menopause, progesterone production stops as well. And what does this mean? Well, absence of the progesterone can mean that your period becomes heavier and longer as well. And then that third hormone, testosterone, which again Dr. Jurić has talked quite a lot about already, we know it's important for estrogen production itself, and it contributes to your libido and your muscle mass and your bone mass. Now here, interestingly, the decline in testosterone is very different to the decline in estrogen, because the levels of testosterone just decline gradually with age. So this is unrelated to the roller coaster of the menopause. Testosterone tends to peak in the 20s and then gradually decline, so that by the menopause, it's usually about half the level of its peak. So you do continue to make, some ovaries do make testosterone even after they've stopped making estrogen. And remember, you also get some testosterone from your adrenal glands as well. So that's probably the kind of three key hormones and those changes that we get through the menopause as well.
Dr. Jurić, you already talked about the role estrogen plays in inflammation, but I want to ask you a bit more specifically with regards to the role of chronic inflammation and biological age in menopause. You did a study in 2020 which I found very interesting. You artificially induced menopause in women who would have otherwise not been menopausal. So could you tell us a bit about the findings?
Yeah, we wanted to see how function of antibodies changes when we were looking at the women who were in their reproductive period of age, healthy, having a normal menstrual cycle. And what happens if those women deplete of their sex hormones and kind of transfer them into the period very similar to menopause? What will happen to those women and with their antibodies and their level of inflammation? And what will happen with their biological aging? How much will it affect their health of the body and aging? And what we did, this was a study on around 40 women. Those women were medically introduced into the menopause, and what we saw is their chronic inflammation level is growing. And this level of inflammation, which was growing in women who were depleted of producing estrogen, progesterone, testosterone, follicle stimulating hormone, luteinizing hormone, so all the sex hormones, could be stopped just by supplementing estradiol. So women who were supplemented with estradiol didn't have increase in chronic inflammation and also didn't have the increase in their biological age. The women who were depleted with their sex hormones, so they were in a state of menopause without any hormonal treatment, aged on average 9 years. So what we were looking is the potential of antibodies to promote inflammation, and this is what we call our glycan age. So what we are looking at is biological aging, but actually what we are measuring is the age of our immune system. And this is pronounced in this transition from regular menstrual cycles to menopause. It's very pronounced that they age biologically, that women age biologically when transitioning from having regular menstrual cycles and producing sex hormones to the period when they are losing this protective power of sex hormones when enter menopause.
And I just want to highlight, if our listeners weren't paying attention, these women aged an average of 9 years in how many months?
The treatment lasted for 6 months. So in 6 months, they aged 9 years on average. Some of them even more, some of them 15. So the ones that aged more were the ones that were biologically younger at the start. So if they had more sex hormones, they aged for about 15 years after we depleted theirs, so they were no longer capable of producing sex hormones.
So I think now we must talk about potential applications of this information, so all of our female listeners in menopause don't panic about aging so fast. So what are the options for women in menopause with regards to biological age?
So one of the options is to track your biological age before you enter menopause, so in this perimenopausal period. So you see how what is the level of your biological aging, what is your curve, and then when you start noticing that it goes slowly up, so you start seeing faster biological aging, then this could be a trigger for you to know that something is going on in your life. So you're probably entering perimenopause if everything else is all right. So if you're healthy, if you're eating normal, if you're not overweight, if you have no other like health issues, and you should start considering replacing the hormones that you need. From our doctors that we are collaborating with, they usually give estrogen to the women who are still menstruating. They give estrogen in the first part of the menstrual cycle, and then they combine it with progesterone. And this is the way how they manage to lower down the symptoms of perimenopause. Women do not feel such big fluctuations, so such dynamic changes, fluctuations in the level of estrogen, progesterone, so everything is really constant. And then you have this effect when you are preventing chronic inflammation to so drastically go up in the period where you have transition from regular menstrual cycles to menopause.
Thank you for giving the list of options, because it's very important to know that there are options, even though there isn't much research on menopause and much research, including women, as we've said in this conversation, there still are options. So I think we've definitely, with this conversation, given some food for thought for our listeners. And before we conclude, could you each mention what you think should be the necessary next steps in research and clinical practice with regards to women's health?
Shall I kick off? Yeah, I can certainly do that. So we've had a really great conversation, and I think talking about research has been really important. I think it's important that the spotlight should not come off research into women's health. We need to continue to spotlight that, and there's certainly organisations, aren't there, like the Society for Women's Health Research, that are championing this. And we know, don't we, that there's biological differences between men and women, but they go way beyond anatomy. We have to really look at that cellular level function. The work that Dr. Jurić's been doing is so critical, because that's where we discover that crucial information about the differences between men and women, our development, our function, our biology. And I think in terms of extrapolating this research that we've got currently into clinical practice, the one thing for me that I've got a very, very strong mantra about is really this sense that n equals 1. So what do I mean by this? Well, what I mean is that whatever the research is telling me, and we've unlocked today that there's inherent biases and significant limitations in the research that we're being fed at the moment, that what n equals 1 means is that the most important person is the person in front of me. It's her story, it's her narrative, it's her experience that really needs to shape the next step. So important to have that attention on that one person, and really personalize care down to cellular level testing, absolutely, and that individual unique experience of being human.
Thank you. And Dr. Jurić?
Well, we are scientists and we are researchers. We are looking at many things, but none of our research would be good if we cannot really help the patient, if we cannot transfer the research to the medical applications, to the technology, to help people with their health and their preventative and personalized approach in treating them, or some kind of a diagnostic test. And what we want is a really good collaboration with the doctors, because they're the ones that are speaking to the patient directly. They know what kind of things should be researched. So we need the input from the doctors, what to look, and they need us for giving them our results and our science to be able to help the patients. So with only with our unique communication, we can make the life of patient better and healthier, to live longer, to have a longer health span, and to do preventative medicine.
Excellent. Could you each tell our listeners how they can reach you, get in touch with you, follow you, if they are interested in your work?
So it's really interesting being on this interview today talking. We talked a lot about pills and medication, and it's really interesting for me because I'm a doctor who has actually transferred from prescribing pills to prescribing lifestyle. And for me, that's really at the core of happy, healthy, long living. And I measure biological age in all of my clients now as a critical piece of data that we should all be mapping to. So really using data to drive that determination to change your lifestyle, and having accurate personalized data is so important. So in terms of working with me, really the way that I work is to measure personalized data and then to map lifestyle changes to that, so you really can see the benefits of those changes for a longer, happier, healthier life for you. And I do this through a number of programs, so listeners are very welcome to reach out through my website. It's www.dralkapatel.com, and I'm also on all the social media as Dr. Alka Patel UK as well. So very happy to hear from anyone who's got any questions or really thinking about making some changes and not sure where to start as well. You're very welcome to get in touch with me. This is the stuff I love talking about. So.
And we will put all the links in the description.
Yes, and I would like to call all the collaborators that want to help their patients track their lifestyle changes to see how much they improved in their biological age, or whether something that they have chosen to work on really helps them, or is it something else they should change in their lifestyle or exercise regimen or dietary habits that will suit them better, to go to Glycanage website and to have a test, so they're sure that these lifestyle changes they are doing are really helping them.
Please don't forget to leave ratings and reviews for this episode and engage with us on social media. Thank you for listening and have a great day.